Hi, everyone. Welcome to the Medcurity Podcast. My name is Mel, and today I have a really special guest with me, Madelaine Yue. Madelaine, welcome to the show.
Thank you so much, Mel. I'm so happy to be here and honored that you guys have invited me to join you with this wonderful dialogue that you're having in the industry today. Um,
Thank you.
do you want me to share a
Yeah,
little bit about my background and everything, just to introduce myself to the audience?
yeah, I would love that. Why don't you start off by telling us a little bit about yourself, and then we'll kind of continue the conversation because we had so many great talks about AI and data and healthcare, and I'm glad to continue the conversation with you.
Sounds good. For those of you who don't know me, my name's Madelaine Yue. I've been in healthcare my entire career, and I have primarily focused on executive strategic alignment, a lot of elements in healthcare IT, but also my background started out with operations. I like to call it my origin story, right? I started out in healthcare operations in a large health system, actually with Kaiser Permanente back in the day. And early in my career, it was all about process improvement, business intelligence, and really leveraging data to accomplish the organizational goals. And this was pre big, large enterprise EHRs. But with the onset of the EHRs, I really saw a shift and a potential opportunity that would change the way we would be doing healthcare. So I could not avoid the attraction to be drawn to the new shiny area of the industry. And I wanted to get engaged, dove straight into Kaiser's engagements with Epic and continued my journey, leaving Kaiser to go into consulting and
Mhm.
really pursued a lot around looking at the different EHR solutions, as well as coming back to my core of strategy with looking at how to evaluate IT roadmaps in advancing not just selection of investments, but really thinking about how do you realize the benefits of it. My educational background is actually in health management and policy. And so there's a part of me that's always drawn to, no matter what you do in healthcare, no matter what your role is in healthcare, you are actually driving life-saving impacts to your community, right? And if you're able to create innovation and help hospitals and providers actually realize those benefits, it's changing what's happening in your community. So I recently have been thinking a lot about, how to articulate what I do and where my career has evolved. And I like to describe it as I'm a transformation architect. I
Mhm.
help healthcare leaders make their big ideas for better patient care come to life using data, human behavior, and smart planning. And so it's really about how do we bring all these systems? How do we actually use strategic alignment, bring all those pieces together, but also think about the people, which, as
Yeah.
you were talking about, all of our wonderful conversations around AI, I really center on that people component as well, and bring that together because the world that we're talking about in the foreseeable near future, looking out 10 years, is all
Mhm.
about human AI collaboration and human technology collaboration to drive things forward. So,
Yeah, absolutely. I mean, AI is not going anywhere, and it's been so neat to see how it's just been changing from personal lives to just to work to healthcare and seeing it rapidly expand. And it's so great that you don't forget that human component and kind of the way that you bring everything together and to uh, you know, understanding that every role within the healthcare system is valuable and by optimizing and that bringing it all together to make a better healthcare experience. That's really great here. Um,
thank you.
so kind of we had such a great conversation a few weeks ago about AI and healthcare. And so I'm thinking, you have so much expertise working with different healthcare organizations and IT and all that. So tell me about kind of governance and proper use cases and with AI in healthcare.
Absolutely. I think it's been an interesting evolution and it's been so rapid over the last 3 years, right? When Gen AI kind of hit the open public visibility and
Hmm.
really kind of launched with all this excitement, but also fear.
Hmm.
At the same time, everyone was very much trying to be intentional about how to prepare for this change. I think some of the conversations I was involved in early on in panels and everything were talking about, you know, even if you as an organization are not ready to embrace a active implementation of AI, and again, this is talking 2, 3 years ago, there are things that you need to start doing, right?
Mhm.
Don't sit back, don't wait too long. Think about what you can do within your organization to start preparing for this upcoming change. This change, the genie's out of the bottle, or whatever you say,
Yeah.
Pandora's box, right? Pandora's box has been opened, there's no closing it, right?
That's
And
so true.
so, right, it's like get back to some of those
AI is
old
not going
analogies.
away.
Yeah, it's not going away. We've opened it, and all those curiosities and everything are coming out. And so, it's important to not be too cautious on it in the sense that you don't want to be left behind. The world is shifting, and this is one of those things that when you think back when the internet came, when even mobile phones, right? We can't live today without mobile phones. And so imagine being at the onset of that and just completely shutting it out and not wanting to do anything with it, right? That would
Yeah.
completely shift how you can move forward in the world. We're at a similar precipice in the world right now, and AI is transforming everything in every industry. But in healthcare, some of those core principles, and I'm so glad that as we've been talking about it, as many of those thought leaders in the industry have been talking about it, organizations are embracing it more and more, is the importance
Yeah.
of governance.
Yeah.
It's not just I go to a conference, I'm, nurse so and so, doctor so and so, or, finance department so and so. I saw something really cool. Let's do it. It's
Yeah.
actually making sure that you have proper stakeholder review that includes
Mhm.
everybody from, your CEO, not just your CEO, CFO, and CIO. You want your compliance
Yeah.
officers. You want actual input from department heads, because if
Yeah.
you don't know what the problems are in your organization, you may be putting a very significant investment that might also have risks to your data.
Yeah.
You guys, Medcurity, you're all about
Yeah,
compliance and
absolutely.
data, and that's you don't want
The
to
human factor
introduce
is a big
something,
one.
right?
Yeah.
That's a huge one, and you don't want to introduce that in a not thoughtful way. And
Yeah.
I was just, I was listening to a couple different podcasts, as well as different conversations that are happening within LinkedIn and other communities. And I love this one statement. Julie Chapman, she's a CISO and CEO of Resilient Tech Advisors. She's not specific to the healthcare industry, but the thing that she calls out is, she's a risk specialist. And
Mhm.
the decision has to be made by business, right?
Yeah.
It's not owned by risk. It's not owned by IT. It's not owned
Yeah.
by the finance department, right? It has to be business driven. And so that means defining proper use cases. What are the
Yeah.
challenges that your organization has? But not just the challenges, also owning the aspect of what's your organization trying to grow towards, your strategic goals for the next 5 years. Are you trying to improve that quality of care? Are you trying to improve your revenue capture because of the changes in reimbursement and the fear of closure, right? Those are things
Yeah.
that you need to find those right use cases. There are lots of proposed advantages of AI. There's lots
Mhm.
of startups out there, but you want to make sure if you're investing in it, number one, it's investing for a challenge that you need to address, that is going
Mhm.
to help your strategic goals and better position your organization, whether it's for better reducing burden for your healthcare workers, et cetera. Or it's you also have to be thoughtful, and this is where your compliance officers, your CIOs, it's really important for them to do their due diligence in providing guidance on the types
Mhm.
of investments you're making as well. And that's where, bringing in that proper evaluation with vendor selection, understanding why, understanding the challenge, but also understanding the ins and outs of each of these organizations. It's not just the dollar that they're sending you, right? It's not just
Yeah.
this is the amount that's going to cost you,
Yeah.
or this is the amount that we think we're going to gain for you, but looking at the viability of these companies as well. There's so many actors out there, and in healthcare AI, the
Yeah.
success rate, the 5 year success rate, those companies that are still viable at 5 years is only 2 to 10%. And
Wow.
so it's really important that you do your due diligence in that evaluation. You're evaluating how are they using your data? Are they using
Yeah.
it in an open platform or in a closed platform? Are they training the data that they're saying does these wonderful things for you based on generalizations or actually on your own data? And so
Yeah.
all of those components are so important for you to be able to make sure that you're putting your money in the right place. These are questions your board is going to ask you, right? Before say
Yeah.
if your board is
Mhm.
super granular in their evaluations, they're going to want approval before you invest in this, right? And so those are all really important things. You also have to think about the human side.
Yeah.
Is how are your staff ready to adapt to this? If there's
Yeah.
interactions that your patients are expected to do with technology in order to support these AI tools, like if you're using a agentic AI for a chat related agentic AI for appointment
Mhm.
reminders, or maybe it's population health, preventative care, visit reminders, and things like that. Are your patients a population that are open and ready to do that? So there may be
Oh,
some
that's a good point.
communities where those patients aren't ready for it, and you might actually get backlash for those types of
Yeah.
services. And so how do you think about that balance is really important. And it also goes to, how you think about implementing. Are you willing to do a full organization implementation of this new feature, or do you have to pilot it?
Mhm.
If you're going to
Yeah.
pilot it, making sure that you have the proper kind of definitions of what's success. So you actually have a defined decision point on when to roll it out further if it is successful, or when to pull it back because it's not successful. So a lot of those are all related to creating that
Yeah.
governance structure, creating a thoughtful engagement, making sure that you have that team that understands how to bring all that together. Yeah.
So when you're thinking about, so say you're in a healthcare leadership shoes and you're trying
Mhm.
to figure out or determine the readiness of your team and whether or not you're going to do a small pilot or just kind of roll something out or, how do you kind of determine, I guess, the readiness of your team? Or do you just kind of dive in and say, hey, we need to do this because the world is changing. And, how do you get that adoption or get people comfortable? I understand you said that there's some organizations or I guess maybe if you're thinking, say, like a rural rural hospitals, or maybe it's just not feasible or doesn't make sense for those population or elderly, say geriatric care specialists, like maybe that's not more reasonable for them. But for what it's just in general when you're trying to assess readiness and kind of deciding between the pilot or versus big bang, like what kinds of things do you think about?
Yeah, that's a great question, Mel, because it's one of those things that each organization has to define a little bit about that themselves, because there's an aspect, especially when I've led strategic advisory consulting groups, right? And the one of the keys that we do is come in and actually do a purposeful dive into the culture,
Hmm.
and we're trying to understand where is that organization today, what's that market look like, and so that's the market look like is helping us understand the community readiness as well, right?
Hmm.
But also the staff readiness for things, and the staff's appetite for change is a big thing. And so it's not, and unfortunately it's not a one size fits all, because every
Yeah.
organization has a um different capacity and is at a different stage in their organizational kind of evolution, I would say, especially with technology. And so but there are organizations where if you have a transformative leader, they can drive something faster with the right backing. So you kind of have to measure where each organization is. So that's the first piece. The second piece is also looking at the strategic goals of the organization. So if you have the right investments, and so this is where it's really that tailoring to the use case. So let's say an example is the organization says, we're going to improve our patient satisfaction, and our goal is to try to really improve our um, bespoke patient care. That's a concept that a
Hmm.
lot of people talk about, right? Really making the community and our patients feel like we're tailoring to them. You can't avoid AI if you want to do that. If you truly want to succeed in that tailored experience, without having a significant increase in resources, like human resources, you would not be able to do that unless you use AI, because you
Yeah.
need to figure out how to understand the needs of each of those patients in order for them to feel that that's a personal connection, right? So
Mhm.
if that's your charge, the key is going to be, how do we craft the what's in it for me, for the
Yeah.
patients in the community, for the
Yeah.
staff that are engaging it, for the technology team, for each level within the organization so that we have the buy-in. So you can
Mhm.
do a big bang, you can do an all-in-one approach for something like that.
Mhm.
But if you're in a community where they could be concerned about technology, you have staff that maybe are a little bit more set in their ways, not ready
Mhm.
for adoption, a pilot approach is not a negative thing. A pilot
Mhm.
approach allows you to put even a smaller dollar investment initially to
Yeah.
kind of focus in on proving that this is successful. So
Yeah.
I wouldn't say one way is better than the other. I think
Mhm.
it's really about what are those barriers, or who are
Yeah.
you trying to convince in order to drive it forward. But I would say the risk of a pilot approach that I've seen many times, and this is not just with AI, I've seen it with teledoc services, um,
Mhm.
remote patient care services, things like that as well, which are actually human clinicians that are engaged, is they succeed in an organization at one department, but then they lose the traction to be able to roll
Oh,
it
okay.
out because there's another initiative that comes up. So that's when I said that you have to have very clear measurements and very
Yeah.
clear kind of milestones for when decisions need to be made, so that you're
Mhm.
not just leaving it hanging there, but actually saying, 3 months after this implementation, we're going to evaluate it. We're not going to decide on the rollout yet because we want to see a 6 month mark, maybe. At six
Yeah.
months, we need as an organization to say who's the next group that's going to implement if it's successful, right? And so
Yeah.
those are the key things. Like that goes back to my origin story with Kaiser. That was amazing thing that I learned there was you can have a strategic goal of, let's say, 85% of patients should get in within 2 weeks after they've been referred to a specialist. Well,
Mhm.
if your organization hasn't ever done that, you need an interim goal.
Mhm.
So, what's the interim measure is maybe get everyone to 70%. And then once we've
Yeah.
got everyone to 70%, take away the interim, now you all have to get to 85%, right? And so that's
Yeah.
where pilots are in a similar stage like that. It's helping to phase in instead of
Yeah.
have a massive change. And it's really a matter of the culture and the buy-in that the leadership team
Yeah.
has in order to support that.
Yeah, that's interesting. And you know, you talk about measuring the success and things like that. And one thing that AI is great at, or as a tool, is measuring, you know, and
Yes,
compiling data and
absolutely.
across the
We have no
board.
excuse because we have,
Yeah.
like, the tools are built in to help with that. I do recommend qualitative measurements as well, though. So there's the
Mhm.
quantitative measurements that AI will get you, absolutely. But make sure to do those surveys. Make sure to do the pulse
Yeah.
check with the people. That comes back to the human factor and the change management. You want
Yeah.
to do pulse checks with your people. You want to make sure the people are understanding, because we are not in a world where humans are replaced. And so we need
Yeah.
to make sure if the humans don't buy in, you're going to get more resistance in that widespread adoption. And so balance the quantitative with the qualitative when you're looking for measures of success.
That's such a great point. Yeah, I was at a cybersecurity conference yesterday, and I
Mhm.
had a great conversation with a data scientist, and we are talking about this exact same thing. You know, the numbers, you have the numbers, and they can tell
Yeah.
you a lot of things, but they don't tell you the full story.
Yes,
Uh,
exactly. And then there's the interpretation of the numbers. So we need to
yeah.
make sure we're very clear on what we're defining as the numbers and how we're interpreting it. Yep. Yeah.
Yeah. So when you're thinking of data and all the different sources that we're collecting it from, and I mean, now there's just this a treasure trove of it.
Hmm.
And you know, one thing I think about is there's probably some organizations that collect more than what is necessary, which isn't the best practice. But maybe there's folks who don't really know what data to collect, or maybe they
Hmm.
think more is better. Um,
Yeah.
and then when you're thinking about it, it's you know your how do you know if your data is clean? And what how do you know what data to collect? How do
Absolutely.
you navigate the data landscape?
That is a really tricky piece. I'm going to go back to one of my passions. I know I've mentioned this one to you before, is even just the complexity of the patient duplication issue and
Mhm.
misidentification of patients. I can speak to all levels of data, and I think I can also talk about another example is the aspect of whether or not you have a single source of truth, a true single source of truth for your data. And so I'll first start off with the patient identifiers and the misalignment. Patient ID Now and AHIMA are extreme advocates out there. Like they're kind of at the forefront of this conversation. They started a patient ID week in May, and in this week or this year, AHIMA actually put out something that was really powerful. That I was like, oh my gosh, that is that really true? And it's, I mean,
Mhm.
I trust their data. They're an amazing source for that. But the point that they made in May this year was, did you know that some patients pay an extra $2,000 per inpatient stay, and
Oh,
others pay
wow.
over $1,700 more per ER visit? And that's due to patient matching errors.
Wow.
And so it's not across everybody, right?
Yeah.
But that shouldn't happen. It's not
Yeah.
appropriate for a patient to have a higher cost out of pocket because of an error that's happening in our systems, right? That's just not an appropriate thing. And
Yeah.
so AHIMA has put out that they believe that we should be able to get to a maintainable 1% or less on patient
Mhm.
error rates. It's inevitable that there will be some patient errors in healthcare. You get patients that come in unconscious and everything, and you have to
Yeah.
start that process, right? But organizations need to manage that and have a better way of managing it. The most recent widespread survey to kind of do a pulse check on this was in
Mhm.
2022, and that was a partnership between Patient ID Now and HIMSS. And apologize, I do have a little bit of allergies, so I'm gonna wipe my nose a
No
little bit
problem.
here. Thankfully, we're in healthcare, so most people understand.
Yeah. Everyone
Um,
understands. We've seen it all.
I am human. I'm not
Yeah.
AI.
Uh,
But
that's how we know you're not in
exactly, I
fake.
just wanted a validation check that I am human. Um,
Madeline has not been cloned.
but the duplication rate in this survey in 2022 estimated that on average organizations are at an estimated 5.5% duplication rate.
Mm.
And more than half of those respondents, that range is actually between 4 to 8%.
Wow.
Now, the reason those numbers don't necessarily sound that bad when you think about, oh, go back to school, 8%, I'm still in an A, right? But when you start looking at it
I
and
love that
magnifying it,
analogy.
right? You magnify it against how many patient visits there are per year. You magnify it now, incorporating it into things like AI, or automation, where you're leveraging that data to potentially make clinical decisions.
Yeah.
That's where this starts becoming more concerning. And so, data cleanliness, there are organizations, there's some wonderful vendors out there that are offering solutions to help organizations work through that data mapping. There
Mhm.
are academic institutions. I know I've had conversations with like University of Pittsburgh. They're very confident. University of Pittsburgh Medical Center is very confident in the level of cleanliness of their data. They have an excellent team that does their patient ID matching and their duplication management. I think it's Orlando Health is able to
Mhm.
successfully maintain um, patient ID errors well under 1%. I think they're closer to the less than 0.5%. And so it's very
Yeah.
feasible out there to be able to do that. And I think just to turn that into a slightly different tone on it is the cost to healthcare. If we
Yeah.
don't start focusing on things like this better, that actual cost to healthcare is not small. They say
Yeah.
that on average, 35% of all denied claims are a result of identification inaccuracies. And
Wow.
that manifests to $1.2 million per year on just trying to work through those aspects, that portion of denial issues. And so they say that when you spread that, that's per healthcare facility, $1.2 million.
Mhm.
So now you look at kind of adding that out and extrapolating that to the cost to the US healthcare system, that's about $6 billion annually.
Yeah, I
And
mean, that just seems like it comes with a whole multitude of, like,
ex-
downstream effects, thinking,
right. And so
"Okay,
you look
there's
at
labor
exactly,
shortages in healthcare," and then do patients already pay a lot for their insurance every month, and then if you think
yep.
of, if they have to take a lab te it could be something just like a lab test, or it could be something even bigger, and,
Oh, well,
you
you
know,
get
there's
down to the heart of it right now
yeah.
is like, now let's look at the clinical impact.
Yeah.
So we've all heard the horror stories ever since we were little, right? Oh, the person
Yeah.
who goes in for surgery and something they do the wrong limb or whatever, right? And it's like
Yeah.
those are related. Those are, of
Yeah.
course, they're anecdotal, but
Yeah.
it's related to the same thing. So there's the cost from a clear dollars, which the good
Yeah.
thing is with denials, there's amazing work out there with there's quite a number of successful vendors that have been doing automation, AI. Magical out of San Francisco is doing agentic AI around
Yeah.
denials and other things, right? And so there's fabulous work that's out there that's been very successful, but still there's kind of this core element around this patient ID mismatching and how do we get better standards. If you're interested in getting involved, go on to AHIMA's site. They have, advocacy programs to try to get better regulations out there and make this come more to the forefront because while we know it's an issue, sometimes we need to work hand in hand with regulations in order to make it as important of an issue for people to address more rapidly. So that's a good one. I want to circle back though, because you also mentioned kind of just data in general, right? So not just
Yeah.
the mismatch. Going back to just data in general, one other example that I think is really meaningful is, again, think about AI, think about automation, it's gleaning information out of our EHRs, right? And
Yeah.
so, in order to create those recommendations, whether it's recommendations for better coding, for better revenue capture, or it's better recommendations for clinical outcomes and giving care teams better information on how to make clinical decisions, like Wellsheet is a fabulous one that does that within its EHR neutral and helps to mine the data to help support that. But one of the
Mhm.
concerns I still have about data cleanliness is thinking about your sources of data. So the assumption when you're applying some of these tools is still most of these vendors are going with your EHR as your core source of truth.
Mhm.
Well, now let's get into some of the more granular components within the EHRs. I'll give an example of cardiac rehab. Cardiac rehab, the accreditation is not within the Epics, the Cerners, the Meditechs, your main EHR. The accreditation is within a niche system. And so, I think I need to update my language on it, but at one point it was called Scott Care. It may have gotten purchased since then,
Mhm.
but they were the accredited software that was utilized to make sure that your cardiac rehab program was up to the highest standard. And so instead of making most of those cardiac rehab programs re-enter that data into their EHR, the Epic, Cerners, et cetera, most
Mhm.
organizations implemented a integration method that was taking the PDF report from
Oh.
Care and bringing it or pulling it into your EHR. It's not discrete data. It's
Mhm.
PDF report, which means it's not RTF data either. So, depending on how you set up your automation and agentic AI and your other AI tools, if it's
Mhm.
only reading RTF, it's going to
Mhm.
miss your PDFs. Is it
Mhm.
doing the scraping from PDFs? There's other systems like Consensus, Titan Intake that do some of
Mhm.
that mining. They use LLMs to mine and scrape the discrete data
Yeah.
out of those PDFs and other things and faxes and stuff. And if you're able to integrate some of those solutions to make
Mhm.
sure that the right data is feeding the algorithms and the training of your AI tools, then you have
Yeah.
more robust. So it doesn't mean that you have to manually clean all of this, but you need to be
Mhm.
very conscientious depending on what the initiative is. So if your use case is specific to cardiac rehab, don't just assume that data's there. You have to
Yeah.
take that step back. If your use case is in prenatal care and you're expecting to look at data from fetal monitoring strips, the majority of data in fetal monitoring strips are not discrete in the EHRs, depending on what EHR you use. And so
Yeah.
those are the types of things that it's not even just the cleanliness, it's how the data is ingested, how the data is being reviewed as you're bringing all these solutions together is really important.
So thinking of just data and over the and changes over time, I'm wondering what your thoughts are on. So is it better because we know that the diagnosis codes, like say like the ICD-10, there was ICD-9, and then there's been some efforts to use like a common language or so that we can have I guess nationally it's easier to transmit data and make sense of it because we're all speaking the same language essentially.
Yeah. Yeah.
So I'm wondering, um in the case of, say, like the cardiac, if I had a long-term condition since I was a younger, and then maybe there's some old school reports and things in the system. And then as things have changed, even just in the past few years, we have more consistency with how things are being, I guess, labeled, and
Hmm.
those like sources of truth and things like that. Is it
Hmm.
better to collect, like look all the way long term, like my past 10 years or 20 years, and just try and find a way to bring all of that together? Or is it better to rely on, okay, say in the past 5 years, we've made so many leaps and bounds in our
Hmm.
technology and
Hmm.
the way that we're even testing for doing labs and things like that. Is it better just to kind of focus on
The
modern
recent data, or
data?
yeah.
Yeah,
You know,
yeah.
that's
What are
that
your thoughts?
that's actually an excellent question, Mel, because it's a question that people had even when they were implementing EHRs, because
Mhm,
there's longitudinal data that's meaningful depending on the specialty, more meaningful on certain specialties than
mhm,
others. Cardiac is a great example. You start looking at population health, mammography history. If you've got patients that have high risk for breast cancer and other cancers, what kind of X-rays? What kind of imaging studies are more meaningful than others. And so I actually am going to sync it because I think there's parallels in those two conversations. Is how do you leverage, if you know data is cleaner as of this point in time, do you just
mhm,
use that, and what are the costs of that,
mhm,
versus how do you bring forward some of that historical data that might have a very big impact on clinical decisions, right?
mhm.
If it's left out, because if you're almost like, I mean, I'll actually even take it a step back. I guess if we went 30 years ago, that's what paper charts were. People didn't have the full
Yeah.
picture, right? So we are still more advanced in the sense that we are not going from a paper world. I'd have to say that some of the work that the health information exchanges and stuff like Commonwealth
Mhm,
and Care Quality are really pushing forward are really fantastic. Really trying to make it more neutral.
mhm,
But one of the things that's been said out there is, it's one thing to send out data consistently, or
mhm,
meet their requirements for it. It's another thing for each of these systems to ingest that data in a way
mhm,
that can be utilized. So it's one
mhm,
thing because even if you think about early stages of those care quality and Commonwealth transactions, it was still
mhm.
more PDF-ish. There were some things
Yeah.
that were discrete, but not the full element. It was hard to mine the data. One of my
Yeah.
cousins is a physician leader in cardiology, and he actually has said that time and time again. And he's like, he's on an Epic platform. He's like, Epic to Epic, amazing, because you can actually
Yeah.
pull it really nicely. But once you start going from multiple EHRs, it's a bigger lift to mine that data and figure it out. But that's again where systems like Wellsheet and stuff are great because they're able to mine the data from multiple sources. But I think what I'd like to call up is the concept of archival. And how do we
Mhm,
start thinking about? I don't think the archives are quite there. Archives have been focused on how do we move that data, that rich data that you've had, whether it was in an old legacy system that you had, or kind of converting data that was on paper or whatever, but it's still
mhm,
kind of accessed but not necessarily discrete. And so that's an important piece, is if that longitudinal data is important, do we need to come up with a way for the archive data to be ingested by those automation and AI tools in order to have a
yeah.
more robust output? That's one possibility. Another possibility, which was definitely done, and there are organizations that help support this, is abstraction work. And abstraction work is the aspect of you define critical data. So you need to work with each of the specialties and the clinicians
Mhm,
to define what are the critical data points that are not in whatever that time frame is of when you went live on your EHR to now. And
mhm,
you know that that needs to be in because it's going to impact your population health program. It's going to impact your chronic conditions management. It's going to impact all these AI tools that you're using. How
mhm,
do you define and use some type of lift? It doesn't have to be manual abstraction because there are ways to do data conversion. So there's data
mhm.
conversion and manual abstraction to be able to put it into the places that you know will feed the right tools as well. That's something that not everyone thinks about. So again, patient ID, the duplication issues is something that not a lot of folks budget for when they're planning for
Yeah.
big transitions, but also data cleanup is something that gets missed a lot in the budgeting in preparation for a big EHR transition or a significant technology implementation where, oh, if we need these data sources, if we have a gap here, how do we fill that gap in order to make sure it's as robust and we're getting what we want out of this investment? Yeah.
Yeah, and kind of thinking of the patient ID issues, like earlier in our conversation, you talked about insurance companies, and I think there was some sort of I know there's a lot of stories in the news about, oh, this person was denied this particular surgery or something like that. But if
Yeah.
you think about it on another in another way, with like this mismatching of patient, this could also be a another way to catch if there was say for instance, I was told I needed some sort of treatment, but
Hmm.
that was because there was a mismatch in the system, and
Hmm.
because the health insurance company was maybe looking at my longitudinal or just all of my like longer health history. They're like, hey, that doesn't make sense for her. And then ta-da, that
Yeah.
that the reason why they denied it was because there's a
Yeah.
mismatch and I shouldn't be having that particular treatment. I
That's
mean, that's
actually,
just an idea, but I
oh
don't know
yeah,
how.
that's, I mean, that's one of the things because the insurance companies, payers adopted automation in
Mhm,
their processes really fast. They
mhm,
realized the people savings, the time, the resource savings in doing that.
mhm.
Unfortunately, what we saw was pretty much, I mean, one of the early fears from 2, 3 years ago was the potential lawsuits related to AI being involved in clinical decision making and
Yeah.
other things. What we found was most of those lawsuits were happening on the payer side because of these
Mhm.
denials and these what would
Yeah.
be considered inappropriate denials. Premier Inc. had a massive study that they released last year that talked about the cost of these denials and how we
Yeah.
need to find some way to bring the payers and providers together,
Mhm.
because the denials, what they discovered is there was a significant percentage of the denials that were being turned down really rapidly. I mean, it was like in less than a minute. And that has to be through automation, right? And so, but
Yeah.
what they also found was, I think it was somewhere around 60 something percent of these denials were overturned once challenged. Which,
Mhm.
if that high of a percentage is being overturned once challenged, there's got to be something wrong in that automation, that
Yeah.
algorithm that is
Yeah.
missing. It's either they're missing something over there and it's too linear in how it was matching things, or there was missing documentation on the other side. It could be both,
Mhm.
right? And
Yeah.
so I'm so excited that, I mean, it's still considered a little bit of the low-hanging fruit, but I'm so excited that there's many AI companies that are trying to tackle this. They're trying
Yeah.
to bring that stuff together.
Mhm.
And I think some of the stuff I'm most excited about, though, circling back to the patient duplication or patient mismatch, is leveraging things like agentic AI to be able to screen that. Because when it's built correctly, it's not just a single output. And that's what I still fear. I don't know for a fact, but I fear
Yeah.
based on the outcomes that we saw with the significant denials that were overturned,
Yeah.
is that there weren't the checks and balances. And
Yeah.
now with agentic AI, you can build in agents that don't require human checks and balances. You can have another
Mhm.
layer that has, you still need human checks and balances to
Yeah.
monitor the dashboards for when things are flagged, but you can actually layer levels of QA. So instead
Yeah.
of having a singular QA, you can layer like 3 agents that are
Mhm.
responsible for QA and create a percentage of confidence based on
Mhm.
that. And that's something that Magical does right now too, which is really
Yeah.
powerful because that has been one of the fears is, okay, if I trust this, what about the hallucinations? What about the biases? What about
Yeah.
XYZ that were all the concerns that were raised early on? Still relevant,
Mhm.
absolutely relevant,
Yeah.
but organizations, these innovators have been
Mhm.
thinking about how to build in stop gaps and mitigations against that
Mhm.
so that you have a
Yeah.
better confidence. And what that does is it keeps the reduction of kind of that manual labor, and allows
Yeah.
the humans to do kind of the more elevated element. So they're actually getting into the deep cases. They're getting into the challenges that we want to investigate more thoroughly to make sure, because maybe the doctor didn't document something, maybe the nurse
Yeah.
missed something when they were documenting some of the pieces on the post-op, or maybe it was on the payer
Yeah.
side, right? It could be on any which side, but by being able to just focus in on the deep ones and know that you have a better confidence rating,
Yeah.
you actually can really help streamline that and improve that ROI and improve that revenue capture, and the reimbursements for hospitals, which in turn, earlier when I was talking about the
Yeah.
community impact when you're working in healthcare, that means these tech companies that help design this are helping to keep small hospitals, at-risk community hospitals open if these
Mhm.
hospitals are able to engage in those tools because they're going to
Yeah.
have better reimbursement, better financial solvency.
Well, and we know like how they're all stretched. Their time, people's time is limited, and if we have, I view, personally, I view the AI is it's an extra set of eyes. It's not,
Yeah.
you still have that human oversight, and
Yeah.
just a personal example. I was billed twice for the same ambulance ride when I had a bad fall and hit my head
Right?
open, and it
How
was,
is that
there's,
right? It's like,
that would
why?
have been
How?
avoided,
Yeah.
but I was like, this is weird. I'm only one person and I can only be in one ambulance at the same time. But and interestingly enough, they were two different prices. Uh,
I hope you argued it to get the lower price.
yeah, I did.
Good, good,
I
good for you.
avoided them, those are things that I think it could have been avoided had there
Absolutely.
just such a simple thing that AI could have been screened through
Absolutely. And
to
those are the benefits too.
claims
It's
and
like
things like
we're
that.
not we're not trying to it's not trying to eliminate the human. And
Mhm.
one of my one of someone I really look up to, right? Jor Amster. He's a global tech exec out of Silicon Valley, and he's also an executive coach and a fabulous man. He's been describing about how with AI, what is the human element that's not going away?
Mhm.
And he describes it as the three C's: curation, curiosity, and connection.
Yeah.
So, AI, and not just AI, technology in general, but AI specifically, because that's what everyone's focused on. AI is mining data. It's mining data to identify patterns and to create summaries for us so that we can ingest more data in a efficient way, right? But
Mhm.
AI cannot say, "Hey, what's going to interest Mel?" It
Mhm.
can mimic if it knows you, Mel, if you've done a lot of input into it, and it can say, based on what I've seen Mel search for, I think Mel's interested. And we've seen that in Google
Mhm.
algorithms, Instagram
Yeah,
algorithms, all of that.
Netflix and
It's
all those
pattern
things.
recognition
Yeah.
still, though. But from our interactions and our conversations, like, it's not able to tailor examples specifically to flow live with this conversation in the same way. And that curation one, the way I like to think about it is, doing strategic advisory and working with executives. A lot of times we're presenting to boards, right? And helping executives present to boards. We can leverage AI to mine a lot of market insights, to mine, even to process data. Like when I said qualitative data to collect survey information of your staff on how they're receiving it, you don't have to sit there manually doing that. You don't even have to rely just on SurveyMonkey and what they put out as the input. You can actually take that full input, put it into AI, even the free text ones, and have AI give you themes, right? And patterns in there so that you can highlight things, and it can give you like a lovely word cloud or whatever, right? But
Yeah.
you still are the person that needs to say, I know how this board thinks. I know
Yeah.
what's meaningful to this board. I know what the CEO likes to
Mhm.
focus on, and curate that presentation to
Mhm.
drive a more effective decision making, to drive a more timely conversation and move forward in that way. AI can't do that piece, right? So that's the
Mhm.
curation component. It's really something that humans can do in a way that, they won't be able, AI won't be able to do for us.
Yeah.
The curiosity component is AI can't create something new. Yes, it can hallucinate occasionally, but that's
Yeah.
still taking data that it is trying to intersect, and maybe it's the mismatch of patients, or
Yeah, there's
maybe
a
it's
little glitch
something
in there.
else. Someone used a
Something that
term
yeah.
that is
Yeah.
the wrong way, and all of a sudden it mined it together, right?
Yeah.
And but the curiosity piece is creating a new thought on top of that,
Mhm.
innovating a new potential. Those are
Yeah.
things that AI can't do. And honestly, in the tech space, I'm in the heart of Silicon Valley. Um, it's not something that's in the next 10 years. There's very few that think it's going to get there in the next 20 years because there's all the people that are talking about, well, there's
The
AGI, like
generalized intel,
the
yeah.
where it gets general intelligence. And
Yeah.
even with that, the potential for that still needs training and
Yeah.
programming, and it's still going to mimic. It's not going to be
Yeah.
the natural human curiosity that we have. And then there's the connectivity. It ties back to that curation example with the board is,
Yeah.
you know, we have a connection, Mel. We've had wonderful
Yeah.
conversations. We've gotten creative and brainstorming about all these
Yeah.
what ifs and possibilities. And that connection, even though there's people, and it's really sad, there's that lawsuit that's out there on the unfortunate suicide case, right? But
Mhm.
and there's guardrails that are put up around it, but
Yeah.
um, that there's unfortunately there's some younger generation that thinks that AI can be their therapist, right?
Yeah.
And what they're not realizing is there's a human relation. We as humans absorb and notice things that
Yeah.
AI is being trained to do. And
Yeah.
so AI will never get to the point where it notices it naturally the way we do.
Yeah.
Even with the AGI, people
Yeah.
are skeptical of AGI being able to get to that point.
Yeah.
And so that those three components are really something that really says that we are going to continue to be in a human AI augmented world,
Yeah.
not in a replacement world for a very long time. And where humans need to focus, I'm going to circle to one of my passionate conversations is around how to help people adjust and grow into this new world.
Yeah.
And I think when you really focus on those three C's, it's really important. But I also think when you look at jobs, the jobs are what people are going to be doing. There's really a lot of interesting new roles
Mhm.
that are coming up in healthcare, and not just in healthcare and across all industries.
Yeah.
And I kind of categorize it into, I kind of bucket into four categories. And these are kind of these new, kind of more AI enabled or augmented
Mhm.
roles. There's the ones that are more traditional that we've already been seeing. It's the people like the developers, the creators or architects is what I call them.
Yeah.
They're creating the new prompts, they're creating the algorithms behind the scenes. They're also designing as architects the
Yeah.
integration with other systems and tools that are out there. Then
Yeah.
I feel like the next category are the roles around guardrails. So these are
Yeah.
the ethicists. These are
Yeah.
the quality assurance people to kind of monitor the hallucinations and potential risk
Mhm.
mitigations. These are the people who are also thinking about how human AI interaction is going to be. These are, so those are the guardrail folks. There's the
Mhm.
guides. There's the people who are training the folks that are new to this so that you understand how to use this and how to use it properly, how to question it
Yeah.
also so that you're bringing your human
Yeah.
factor into it. But there are also those guides that are guides to AI. So you have to
Yeah.
train AI to work and function in the capacity that you need it to. So there's human guides as well as AI guides. And then there's the curators, which I love the most because I think those are the fun ones, which it's, you're helping to shape how AI is being utilized, curating almost the
Yeah.
world of the storytelling, the decision making, and the business decisions, and how that
Yeah.
information, discerning what information actually drives and can be responded to and absorbed by humans in a way that will take us forward. And so I
Yeah.
really see those
That's so
as kind of
interesting.
the new roles, and those are the categories of those roles that we're going to continue to see grow a lot in the next
Mhm.
decade. So
Yeah, that's so interesting that you talk because when core theme is the human factor, the humans. You don't leave out the humans, and when you talk about the curation and the data collection, at the end of the day, the AI is existing. It's hoovering up our data, but we're basically shaping and choosing what AI moves forward because
yeah,
if it's not adopted by people, it's not going to continue because you mentioned that there's a small percentage of specifically in healthcare that like continue to move forward. And how do you think that is, or why is that? That's because it's the adoption and that's the people and the use cases. So perhaps in the 10, 20 years, maybe there is a possibility that humans could create the AGI, but would it actually happen? I don't know if people don't use the tool, like they're not going to build it if people are saying we don't have a use case, we're not going to use it, we don't want it, we're not feeding it, whatever it is. It's interesting. I think that we are shaping all collectively, we're shaping the future of
We
AI.
are. It's side by side. It's just like the
Yeah.
internet, right? The internet was shaped by us adopting it. All the
Yeah.
information that's out there, and AI can't exist without us having evolved to the internet too, right?
Yeah.
Because it's mining all that data that's out there.
Yeah.
And so I actually want to hit home because as you called back to kind of the success rate today, you actually nailed it. It's one of the biggest failures or one of the biggest reasons for failure in the healthcare AI market specifically is a misalignment with real needs. So
Mhm.
really understanding the business and clinical needs, and that misalignment is the aspect that's so important to address when there is good potential. And that's why a lot of these companies are looking at and seeking advisors, right? They want advisors that have deep knowledge in the payer space, in the provider space, in the regulatory space, because if they don't get that right, they are not
Mhm.
going to succeed. And that's the biggest failure point. But the other big challenges that these organizations are facing is the regulatory, the data privacy, and the integration. And so, I mean, it really ties into your world is going to continue to shift. I mean, I know Medcurity does an amazing job with the compliance aspects and really helping organizations prepare for their compliance audits and monitor and address the challenges or issues that they have. But that continues to grow in this
Yeah.
technology space because as you incorporate more of these, that third party risk, that those
Yeah.
technology risks are things that need to be focused on. And I think there's also this other piece that is definitely out there, has been talked about a lot, is the increase in cyber attacks that
Mhm.
leverage AI for
Yeah.
cyber attacks. And so
Yeah.
there's always that underlying kind of concern that we still will have.
Yeah.
The fears start shifting as things get adopted more, but there's still a lot that we have to worry about out there. And of course, healthcare being one of the biggest targets in
Yeah.
cybersecurity concerns is a big thing. So,
Yeah, yeah. Speaking of the AI and cybersecurity, phishing attacks, that's something that where the human factor is necessary in order for there to be a successful phishing attack. So,
yep.
and with the skyrocketing use of AI by threat actors, I mean, the cybersecurity teams, like the red, blue, they're trying to all, keep up with
Yep.
the speed of change and things like that. And
Absolutely.
with voice cloning, one of the things that we're actually working on, we haven't decided on the name, so don't get too
We'll
excited.
have to
But
wait for
basically,
that
it's a
announcement.
yeah,
Yeah.
yeah, phishing simulation. But it's so cool, and we've been playing with it in the office, and it's amazing how little a small snippet of somebody's voice that AI can clone it and then continue, and it can
Yes.
call, like, we tested it on each other where somebody from somebody we cloned our CEO's voice and had him call our IT one of our IT leaders and say, "Hey, I understand we changed our Wi-Fi password last week. I'm at my desk and I can't seem to log in. Can you?" And it sounded
It's
so
insane.
much like him. There was
Hmm.
pieces of it where it sounded exactly like his voice, and this AI was it was dynamic.
Yeah.
It wasn't reading from a script. It
Yeah.
was reacting to,
Yeah.
our IT folks, the way that
Yeah.
he was talking and what he was saying, and it was
Yeah.
mind-blowing. So, you know,
That's
don't forget the human
so
factor, but it
it's
was amazing.
crazy and it changes because I mean, especially in the world that you guys are in, is when you think about those compliance audits, it's also the training of the
Mhm,
staff for those risks, right? We all have those phishing exercises that our organizations send to us. At some point, we're going to have voice phishing exercises as well,
yeah,
because that's definitely a risk. And I mean, I'm going to shift a little bit to the positive spin just because as you
yeah,
were talking about that, that actually got me really excited about some of the other potentials we have. So,
yeah,
kind of, I know we're probably getting close to time and
yeah,
everything. And one of the things I love is And one of the reasons kind of I've done a shift in my career, right, is trying to make sure that in my next chapter, I'm able to focus a little bit more on that technology innovation. Is that there is so much potential.
Yeah.
Yes, there's fears. Yes, there's risks. But and this again goes to the human curiosity, right? The
Yeah. My
innovation and the
excitement is
potential,
more than fear
right?
for
It's like
riding
there's
it.
so
So
much.
go.
And so
Yeah.
just the voice piece,
Yeah.
they've already had organizations that were working on this, but it's going to advance that much more with AI
Yeah.
is translation. So
Hmm.
imagine the patient interactions and the connectivity that you can create with your provider if your provider can do a live translation with AI.
Hmm.
So I speak I speak Cantonese, not fluently. I used to have to go with my grandma to help her translate for her doctor.
Hmm.
Imagine if the doctor can do whether it's a video call or even live and have that translation come out in their voice.
Oh,
There
that's
are
so
there
cool.
are
Yeah.
organizations, there's companies that have that type of tool available. They haven't focused it on healthcare. They've used it in some of these other fields in entertainment and marketing, but
Hmm.
movies can now do, instead of hiring a foreign voice that's similar, they can actually take Tom Cruise's voice and translate it into that language to make it sound like Tom Cruise is speaking in that native tongue. And
Yeah.
so that, imagine again, going back to organizational goals of bespoke, tailored, patient-centered care for a patient that doesn't speak their physician's language to feel better connection because it's almost like you're speaking live with your physician, right? And so
Yeah.
those types of things are really cool. Obviously, the risk there is they come and see their physician in person and think their physician speaks their language, and the physician's like,
Yeah,
"Give
that's
me
true.
a second to get my phone out," right? Um, so that's really cool. Another one that I'm like super excited about. I haven't seen anyone try to do this yet, but it's taking the Vision AI technology that all of our cars have. So look at Vision AI in our cars. Vision AI allows our cars to have the ones that have, like, if you have the souped up ones that have those
Yeah.
chips that do the video sensors. We're all annoyed when your car beeps because
Yeah.
I'm still 2 feet from that spot and you're beeping at me, but it's beeping at me, or I'm going through the car wash and it's beeping at me. But those are Vision AI. And Vision
Mhm.
AI allows real time reaction to the space based on the cameras absorbing
Mhm.
and the defined risks associated with it. Now let's take it to the next level for healthcare and quality of care. Let's take it to we all know in healthcare that hand washing is the
Yeah.
biggest preventer of hospital associated infections. It is the best thing to reduce the risk of hospital associated infections. Hand washing still becomes challenging because we have overburdened clinicians that,
Mhm.
if they're in a rush, they get called to an emergency. All of a sudden, it's
Yeah.
like, but how do we help
They're not sitting
them
there singing
remember?
happy birthday, washing their hands. They don't have
Yeah,
time.
that's
Someone's
singing happy birthday.
flatlining.
So now let's envision they've already executed versions of Vision AI to help reduce fall risk for patients. So there's companies that have video camera to be able to go to a monitoring station at the nurse's station on if the patient's a fall risk, to make sure, oh, there's movement. The movement's significant enough that we should go check on them and maybe make sure that we're shifting them a bit in the bed.
Mhm.
Now let's take that Vision AI to have live real-time sensors. So when the nurse or the doctor forgets to wash their hands before exiting the room, there's a little light that flashes in the room. Maybe it's blue for water. I don't know. We haven't defined the color
Yeah.
yet. I could spend hours picking colors, but maybe it's a
Yeah.
blue light, and they see the blue light on the door, right next to the door before they leave because they forgot to wash their hands. Immediately they can stop and wash their hands.
Yeah.
Could you
Well, that's
imagine
amazing.
that
Yeah.
small of a thing could have a
Yeah.
huge impact on reducing hospital associated infections? Those are the types of things that we aren't there
Yeah.
yet, but we have the potential to get there. There's so much that
Yeah.
the technology is going to be able to take us forward. Agentic AI I saw the demo at Vive by one organization, that they had kind of the interaction of the AI agent calling a patient to, help them get their preventative care scheduled, and the patient is asking them questions about other things, and they're going through,
Yeah.
if they have the proper guardrails, like
Yeah.
oh, that level of detail, I'm going to put notes in there so your doctor remembers to go
Yeah.
over that with you when you come in. But they're able to cover many of the information, like, oh, this was your lab result, you didn't see that lab result yet, here's what that lab result was, and able to do a lot of those elements to help reduce the manual labor, again, not to eliminate the humans, but because we've been so resource short for so long, those humans can
Yeah.
do other actions, right? And so those are really powerful things. So we're still addressing a lot of low-hanging fruit, and there's so much potential that's so exciting.
That's what you're describing with the communication. That sounds very familiar, and I mean, there could be more than one. I'm not sure, but
There's a
he
couple of
might
them.
have been. I might have talked to somebody. They might have come on our podcast earlier in after Vive. I think it was in. I want to say late spring, but it sounds familiar.
Possibly.
I'm
There was
not
a
going to say
really
the
cool
name in
demo
case
at
you mess up,
Vive.
but yeah,
It was
but
pretty
it was so
amazing.
cool.
Yeah.
Yeah.
And I
So
mean,
is there?
I think Epic did a couple fabulous demos at their UGM as well of some of their innovations in that space. And so it's so exciting. There's so many
Yeah.
wonderful things that are happening. And I really do say that, it feels a lot like, the Industrial Revolution. I mean,
Yeah. It does.
I
Yeah.
don't think it's too small to say that. I mean, some people,
No.
when you make grand statements like that, some people get a little offended by it, but there were leaps and bounds that jumped forward at certain moments in history.
Yeah.
And cell phone mobile phone was one
Yeah.
phone in general.
Yeah.
When
Yeah.
Alexander
I
Graham
remember
Bell
when the
invented that
smartphone came out
communication.
and there were no
Let's go
buttons.
back
I'm
even
like, how am
further,
I
right?
supposed to type?
Yeah, the phone, like electricity. But
Yeah.
this is really leaps and
Yeah.
bounds forward. I heard someone say that jobs, like kids graduating from high school today, and when they graduate from university, the likelihood that they're going to have a job that we have never heard of is like probably like more than 70%
Oh
chance that
wow.
they're going to have
That's
jobs that we've
crazy.
never heard of. And so it's super exciting. It's like when you're in the middle of such a transformative moment in history, it's just phenomenal. So
So I have two last things before we
okay.
wrap up because we're running a long time. I would like to know kind of like what is something that you're hoping to see in healthcare as far as like AI tools? Maybe it doesn't exist, or maybe it's something new that you're seeing it grow, and maybe you're kind of hoping that, or like what are you kind of most excited about? And then what would you like if there's one thing you could kind of leave everyone with today, what would you say?
I think the most excited to see that I haven't seen addressed yet, or I haven't seen people focused on yet. Um, I Early in my career, I was focused a lot on quality and population health.
Hmm.
And I see that with all the data out there, while there are like registry tools, there's a lot of tools that have been using, kind of algorithmic information. I would
Hmm.
love to see that carried forward. It's almost a marrying of that agentic AI call agent with kind of this information. I also think about the quality stuff. Like when we had meaningful use and everything, a lot of that was ECQMs, the electronic clinical quality metrics, and I see that there's a lot of power in driving improved quality of care, which will have
Hmm.
an impact on the cost of care in our nation as well. Is if
Hmm.
we can improve the health of the population, that
Hmm.
there's study after study that says that will reduce the cost as we have an aging population. And so
Yeah.
I would like to see some focused attention in that area. I know we have a lot of low-hanging fruit, so I still think this is probably several years
Yeah.
out before we're going to have a lot.
Yeah.
But I put little seeds into a number of the
Yeah.
vendors that I've been working with to try to get them to think about it. But I really see that there's opportunity there because there are financial
Yeah.
elements associated with that because there are penalties that hospitals are getting today. There are things that they could be doing better, and they would want to. Clinicians want to do better. They're ultimately, when you get into healthcare as a clinician, you care about that patient outcomes, and so I could see that being really powerful. And we
Yeah.
could do things like I look at quality care audits. Like you guys come from a compliance audit side. When you think
Yeah.
about quality audits, quality departments in hospitals are usually not very big. You get big health systems and they're going to get big, but in individual hospitals, you might have, 2 to 3 people in their quality department if you get a mid-sized hospital, and they are supposed to do chart audits. And
Hmm.
the manual labor to do chart audits is insane. And now you get
Hmm.
into the rural hospitals, they're even smaller, right? And so, like, could you imagine leveraging AI tools to create heat maps so that they don't have to do every chart? You have, you know, technology helping to do wide sweeps, allowing the humans with their detailed knowledge, because they are usually clinicians, to be able to do that level of audit. They can go into the deep dives. And so you get heat maps to allow the humans to focus in on what are the bigger concerns to actually make significant change and improvements. I think that's really powerful, and doing that as well with population health. So that's the innovation that I'd like to see, and I'm hoping to see. Um,
I hope so too.
yeah,
That's
I think
yeah.
it gets back to my heart and soul being focused on kind of health policy in general,
Mhm.
and seeing that improvement. What do I want to leave with? I think there's two things I want to leave with. Again, centering on the human side. We all have a role in this. We have a lot of opportunity as humans in this augmented world. Again, I want to say don't shy away, because similar
Yeah.
to like the mobile phone and everything else, we've been using this. Algorithms, AI are in our daily life, and it's no different in our work life that we can adopt this and bring this forward in a meaningful way.
Yeah.
And so I think humans making sure for healthcare organizations to, and payer or provider or tech, how do you help your staff know how powerful it is? But also from a tech side, how do you make sure your team is thinking about the human side as you're bringing this
Yeah.
forward to your customers? And then from a hospital provider payer side, how do you make sure that you're thinking about the human role and not shying from those questions to make sure that it is a human tech collaboration in this new world? I think that's really important. The second thing I would hone in on is it's related to that governance and return on investment.
Mhm.
A good friend of mine, Jeff Barnes at Innova, he put a couple blogs out this week around ROI in AI, and it is, he categorizes it really nicely: financial, clinical, and operational.
Mhm.
So you need to make sure you're defining metrics for success across all three of those. And then I would add Dr. David Kirk from Wake Med added into that discussion
Mhm.
the aspect of thinking through how to articulate the healthcare worker experience, because it comes back to the human again. So
Yeah.
yes,
Yeah.
financial, clinical, and operational is important, and it drives the core elements of any health hospital or health system. But the worker, without the worker, you still don't have
Yeah.
healthcare. We're not short, we need workers,
Yeah.
and we
Yeah.
are resource constrained in healthcare. And so making sure that, and I consider that a matrix across all three, right? The healthcare worker
Yeah.
experience, you can tie metrics that link to financial, that link to clinical, and link to operational. But I think it's really understanding your investment. You're not going into this for shiny stuff. Although I
Yeah.
love the shiny stuff, I'm like
Yeah.
everyone
You're
else.
so
Shiny is
right.
fun.
Yeah.
Shiny object syndrome, but
Yeah.
it needs to do something right for the organization. I think EHRs were a big shiny object. EHRs have done a lot, but there are still organizations that struggle with their full return on investment on that. And so it's we need to get back to the return on investment and think about that as a core in both provider and payer side. Yeah.
Mhm. Wonderful. Thanks so much, Madeline. That's all good advice. And I love how it all comes together really nicely. The different elements, the human, the technology, and all of that. So, as always, I enjoyed our conversation so much. And thank you so much for being on the Medcurity podcast. And
Thank
thank you,
you.
everyone, for tuning in.
Thank you so much, Mal, and thank you everyone who listened.